everybody. All right. Well, it's 7:35. It is also 2025. This is our first Global POCUS collaborative of the new year. And I am just so super excited to introduce our presenter for today. So Dr. Josh Ferreri grew up in Colorado, where he studied environmental health at Colorado State University with a particular focus on the relationship between environmental disasters and human health. Once he graduated, he attended the University of Colorado for medical school and then matched for residency at the University of Cincinnati, where he completed his training in emergency medicine. He is now a critical care fellow here at the University of Washington, and he has a particular interest in the use of bedside point of care ultrasound for the diagnosis and management of critically ill patients, including those that are not only in the emergency department, but also in the ICU. And the one thing I will say about Dr. Ferreri that I just really loved and shows kind of his passion for this area that we all are passionate about is that even before he started as a fellow, he contacted me and said, "Hey, I'm coming to the UW and I am really interested in point of care ultrasound and I want to figure out how to be involved and what things to do and how to grow myself in this area." And I can tell you for a fact, he's going to present some pretty cool cases today that you're going to have to think about and be really excited to see. So without any further ado, Dr. Ferreri, take it away.
Thank you so much for that introduction. That was too kind. It's good to meet everybody this morning, and it's seriously an honor to be able to present with you all today and be a part of this collaborative. Happy New Year. So today we'll be doing some cases, specifically just some cases that I've collected from the ICU. I really want this to be something that's conversational and is a discussion. So please feel free to unmute yourselves and pitch in and chime in. I'm going to do my best to monitor the chat. I have to admit that I'm not the most technologically savvy. So if anybody else, if anything pops up into the chat, Dr. Nick Ravan, if you wouldn't mind telling me, that would be awesome.
I'd be happy to.
Awesome. Thank you. And again, any questions that come up, please don't hesitate to ask. All right, so really quickly, we'll get started. So I have no disclosures. And briefly, just wanted to go over some of our objectives. So for today, we're going to participate in a few different cases. They're of varying lengths, so it's totally okay if we spend more time on one than another. And if we miss one in the end, that's fine too. We can always circle back to it at another time. I really want these cases to help us identify the utility of using point of care ultrasound in ICU patient management. And kind of actively provide direct interpretation of these ultrasound images to really apply them to how we manage the patient in front of us. The outline for today, so we'll participate in scenario 1. After that, we'll discuss some key learning points and kind of review the case. We'll then do scenario 2 and similarly discuss some key learning points, and then we'll finish up with scenario 3 and a little conversation of key learning points for that as well. So we'll go ahead and just dive in. So we'll start with scenario 1. And like many scenarios, this scenario begins with a page, and it's a page from the floor. And you have a patient who's presenting, it's a 41-year-old person. They initially presented to the hospital with concern for wheezing. They had some shortness of breath, and they were also noted to have a pretty significant amount of volume overload. At this time, they were admitted to the hospital for a suspected COPD exacerbation, as well as concern for possible CHF exacerbation, and had been treated for the last couple of days on the floor. However, you're talking with the triage provider who's sending this patient up to you, and they said that they had really been doing quite well with diuresis and COPD treatment until this morning. This morning, they all of a sudden were noted to have some increased anxiety. They seemed to be more stressed, and then shortly after evaluation, they started complaining of severe shortness of breath. At this time, they got a pulse ox and oxygen saturation at bedside, which ultimately showed an oxygen saturation of 49% on room air. And they immediately paged you for transfer and for evaluation. She has one peripheral IV, and they tell you that it's unfortunately not flushing or drawing. And so everybody, as you might imagine, is pretty frantic at this time. While the patient's on the way up to you, you have a little bit of time to review some of the medical history. So I'll let you take a second just to review the history here, but I'll highlight the key points. So she has a history of pulmonary embolism for which she's on apixaban. She's got a history of CHF, hypertension, and COPD. She's been receiving appropriate therapies for all of these since she's been in the hospital, and had been taking most of her medications prior to coming into the hospital, with the exception of her Lasix. She has no allergies, no surgical history, and she does have a pretty significant smoking history, as you can see here. All right. So she finally makes it up to you. And again, I know that there's a lot of text on this slide, so I'll highlight the key points. But really what you find yourself looking at is a patient who's in severe distress. They're in tripod position. They're very diaphoretic and they have severe increased work of breathing. You look at the monitor and you see her vital signs. She's tachycardic to 103. She's very hypertensive with a blood pressure of 205 over 134. She's tachypnic and her oxygen saturation, even on a non-rebreather, is 70%. She's very tachycardic, but you don't appreciate any other significant findings on her cardiovascular examination. And she's pretty cool to the touch when you feel her extremities. So when I approach these patients, I always like to take a second and just ask myself, first and foremost, how I approach this patient and what specific diagnoses am I most concerned about? And specifically, what diagnoses can I potentially even rule out, or at least alter my differential diagnosis using things like point of care ultrasound at the bedside. So I'm going to open it up really quickly to everybody. If you guys wouldn't mind just throwing out a couple of ideas, that would be awesome.
Another big PE despite being anticoagulated, and then a pneumothorax given the respiratory distress and probably underlying lung disease.
Yeah, absolutely. Absolutely. What other thoughts do we have?
A hypertensive emergency, like with congestive symptoms, could be part of it, or just that diagnosis as well. But I do have to say, you're doing this while you're preparing to intubate this patient. You just want that other information so that you could do the job properly without causing decompensation.
What about fluid overload? Fluid overload you mentioned in the history. So pulmonary edema because of fluid overload. I think you mentioned in the history there was some concern.
Yeah, so Compilled said pulmonary edema because of fluid overload may be an option.
Awesome. Awesome. I think that those are all fantastic thoughts, and were certainly the thoughts that were going through the team's head at the time. So what sorts of ultrasound images would you want to obtain at the bedside, especially, obviously while you're getting all of your airway supply set up and everything?
Long cardiac and a fast to look for pleural effusions.
Awesome.
Specifically.
Great. Thank you. So moving in, so we do exactly that. So we start off with an echocardiogram. And so here's the first image. And again, since we're really trying to walk through cases and apply some of the things that I know that you guys have been talking about over the last year, I'd really love to make this interactive. So would somebody be willing to chime in and see what they're seeing, say what they're seeing here?
Yeah, EPSS seems low, seems high, I mean, so maybe ejection fraction is low.
Awesome. Yeah, exactly. So this is a parasternal long axis. We're using the cardiac probe here. And yes, exactly. You can see that if we were to do an EPSS here, if we were to put M mode through that mitral valve leaflet, it would most likely be high, suggesting a reduced ejection fraction or reduced left ventricular function. There's a couple of additional things here that I just like to point out when I'm looking at parasternal long axis views. One of which is just I always look for that descending thoracic aorta, which we're seeing in view here. That's something that I personally utilize a lot in trying to differentiate pericardial effusion from pleural effusion. If I see that, we can kind of talk about that a little bit in a little while, but ultimately here, I'm not seeing any major pericardial effusions, and I agree the ejection fraction does seem to be blunted. Go
If
ahead.
I can just clarify for everyone who may not remember, EPSS stands for E-point septal separation. And basically it's another kind of quantitative tool that's been looked at to kind of correlate towards left ventricular function. And basically the concept is that when the LV function is really good, the mitral valve leaflets open up, and that anterior leaflet, and I don't know, Josh, if you can point to it. Yeah, that anterior leaflet will fly open and touch almost the septum. It gets very close to the septum when the LV function is good. But when the LV function is bad, if you can imagine, the pressures inside of the LV start to go up. And therefore, when the mitral valve leaflets open to allow for filling of the LV and diastole, the pressures equalize pretty quickly and they don't open that much. So they just open and then they close. So that distance between the anterior leaflet and the septum increases. And so we call that an E-point early filling in diastole is what E stands for, an E-point septal separation. So that's what that means.
Awesome. Thank you so much for the clarification there too. Great.
I would also say that there doesn't appear to be a left-sided pleural effusion as you were talking about looking at the aorta. And also the heart doesn't really look that thick. I'm saying this because, I mean, this isn't the best view, but right off the top, it doesn't look like there's terrible LVH. I'm just putting that in the back of my mind as I look at other images. Because
Awesome.
we're talking about a hypertensive crisis just as part of this. Yeah.
Yep, absolutely. Absolutely. And Dr. Gupta, I saw you had come off mute briefly there. Did you have anything else to add?
Yeah, I thought maybe there are B lines visible here on the left lower side as well. So
Yeah, I think that that's a very astute observation for sure. And we'll definitely take a closer look at the lung windows here shortly. But something that I would keep in the back of my mind as well. All right, so you get your next image here. Again, I think making this as interactive as possible, if somebody wouldn't mind sharing what image this is and what they're noticing. And I'll jump in on this one. So what we're seeing here is a parasternal short axis view. So when I do my echocardiograms, I really kind of think of a clock as far as where my indicator is pointing. And so initially, when you do your parasternal long axis view, you kind of have the indicator pointing towards the patient's right shoulder slightly. Here, you just transition that indicator to point up and slightly to the patient's left shoulder. So almost rotating 90 degrees. And that oftentimes gives you this nice view of the left ventricle kind of transected. So here we're seeing the left ventricle transected at the level of the papillary muscles. So you can see the papillary muscles here. And this is just very slightly off axis. And there's a couple of things that I want to mention here. So sometimes you can see a good portion of the right ventricle up here as well, in addition to the intraventricular septum. And so this particular view can give you a lot of information. I think one thing that I'm really looking at, especially in this patient where I believe they have reduced ejection fraction or significant reduction in their left ventricular function, is I really look at that overall squeeze. And so looking at this just kind of without doing any calculations, it just seems to me like the left ventricle is not squeezing quite as well concentrically as I would expect it to. that chamber volume or the diameter of the left ventricle doesn't seem to be changing a significant amount. If you wanted to, you could put M mode through this and you could actually calculate something called fractional shortening. And that would basically be a way to quantify the percentage of which that diameter is changing. And that's something that you could absolutely do. But just visually and based off of Gestalt, this looks like reduced left ventricular function. There also seems to be a little bit of regional wall motion abnormalities here as well, which could certainly be something that's new. But it could be something that's more long-standing for the patient, and sometimes it would be helpful to compare to prior images if you have them. But obviously, we're not doing that in this patient where she's acutely decompensating in front of you. Does anybody have anything else to add on this picture before we jump into the next view?
The only other thing, there's just 2 points to make. One is look at the interventricular septum, and the way that it's moving is very abnormal. And if you look at it, it looks like, if you're very kind of looking at it carefully, that it's flattening in systole. As the heart is squeezing, especially in the latter parts of systole, you can see it just kind of dip down and flatten. So that's a sign of pressure overload on the right side, which tells you that something's going on that's affecting the pulmonary pressures. So now we've been really focused on the left ventricle and what the left ventricle is doing, but there is some effect on the right side too, and you can tell that by this. The other point is really kind of important to bring across is that although fractional shortening, which is a measurement, it's a linear measurement comparing kind of 2 walls of the left ventricle and how they're moving over the cardiac cycle in comparison to each other, is an easy linear tool to use. When you have a patient who has regional wall motion abnormalities, you can't use it anymore because it's not reliable. You may be comparing a wall that doesn't move well to one that does, or maybe missing the regional wall motion abnormalities altogether. So it may either lure you into a sense that things are worse than they are or better than they are. And it has to be kind of not really used in those patients. But to me, it strikes me that the septum is flattening.
Absolutely. Thank you. And we'll kind of in this next view too see a little bit more of that. And we can comment on that on the next picture as well. Let's see here. All right. So you go ahead and get your next view. And again, thinking about your positioning of the probe as kind of a clock, you're now rotating another 90 degrees towards the patient's left, and you're sliding down oftentimes to the point of maximal impulse, or kind of just in that inframammary fold, to try and get this view. Can somebody tell me what view we're getting here and what they're seeing? I'm also happy to walk through this one, but
Apical 4.
yeah, awesome.
And it does look like the RV is a little big. You can't really see the entire RV there. Also looks like the LV function is not normal.
Yep, I totally agree. I think the thing that really stood out to me on this particular view was the RV to LV ratio appears to be approaching almost 1, which kind of goes back to Dr. Nick Ravan's initial comment that there might be some evidence of right ventricular increased pressures to the right ventricle or the right side of the heart. And you can really see that too, because the right atrium appears to be quite dilated, especially in comparison to the left atrium here. So that increases my suspicion that there's some underlying increased pulmonary pressures that could be causing some dysfunction on the right side. Again, we're not seeing the full right ventricular wall. So it's difficult to calculate, or at least get kind of a pseudo calculation for right ventricular function. So something that I don't know if you guys discussed or not, but something that you can calculate is called a TAPSE. So that's kind of a shorthand. And that's really looking at the motion of the tricuspid valve as it moves in kind of I guess a vertical plane would be the best way to describe it. and you put M mode through that particular part of the wall and see if it's moving the way that you would expect it to. And so as opposed to EPSS, you're actually looking for a little bit bigger of a number here. And again, this will maybe a little bit beyond what we're talking about just right now, but that is some calculation that you could do if you wanted to. Okay, moving on to the next picture. All right. So again, we still have a cardiac probe. And here we're looking at a subcostal view. So we kind of slid underneath the ribs here. So we're seeing a little bit of the liver anteriorly here. And then we're seeing a nice view of all four chambers of the heart. One thing I want to point out here is there's actually this hypoechoic kind of density here between the liver and the pericardial edge. Does somebody know what we're looking at here?
Effusion.
Yeah, excellent. Yeah, so this is a pericardial effusion here. And so just again, looking at it, I don't see that it's entirely encasing the heart here. It doesn't appear to be circumferential. And we're not really seeing a significant amount of impedance on the right side of the heart. So reassuring against cardiac tamponade, but it's definitely something that we would want to consider on our differential diagnosis in this patient who's in extremis. All right, and then our last echocardiographic view, this is a view of the inferior vena cava. So you can see the IVC here between the liver, or within the liver, excuse me. And you can see that it's dumping to the right side of the heart. So this is a very nice view of the IVC. And what we're seeing is that with respirations, there really doesn't seem to be a considerable amount of variation. And so that's concerning for maybe some component of volume overload. Or decreased volume responsiveness. I'm just looking at the chat here really quickly. That's a very good question. Let's see. Very good question, Dr. Nathwani. So as far as ruling out an anterior fat pad, so Dr. Nickaravan can probably speak to this a little bit better than myself, but my understanding is oftentimes you'll actually see that anterior fat pad moving with the motion of the pericardium, and it's oftentimes much thinner. So I don't see it quite as, I'm going to go back to the last slide here. We don't see it quite as prominent here, but you can see that it's really not, there's no motion with that ventricular wall.
That's a really good point, Josh, is that it does usually move with the pericardium. Additionally, it doesn't increase in size the way that you're seeing this increase in size in systole. So a pericardial effusion is kind of graded by its size in diastole because, of course, it always gets bigger when the heart is smaller. So in systole, they'll typically look larger, the effusions will. So that doesn't usually happen to a fat pad. The other thing is that usually fat pads have kind of a more kind of homogeneous like appearance, almost like you would expect of a clot or some sort of organ or so. They don't appear so black as you're seeing here like fluid will. But Raj, this is a really good point because I got stumped just the other day on a fat pad thinking potentially that it was a clot or a thrombus in a patient who had received ACLS. They can be very, very tricky. They can be really tricky, but typically if you see it like this, so black and changing in size over the cardiac cycle, that would be pretty good to rule out that it's a fat pad.
Awesome. Thank you for that. I'm also seeing that we're already at almost 8 o'clock. So please interject if we need to speed things up or anything. But in the meantime, we'll keep going through the cases. Okay, excellent. So that kind of wraps up our echocardiogram for this patient. And ultimately, just to summarize some of the things that you all pointed out, it appears that we have a patient here who's got reduced left ventricular function. They have evidence of a pericardial effusion as well as a dilated IVC. And in addition to that, Dr. Gupta, you had mentioned that there was what looked like maybe some B lines in the background of especially the parasternal long axis view. So now moving into your lung examination, you get the curvilinear probe here. And right here, you're looking at the right anterior kind of midline here. And what are you seeing here?
Yeah, you see B lines all over.
Yeah, exactly. So these big kind of vertical, almost spotlight appearing lines, and you see multiple B lines, and you can see that they're kind of in multiple different rib spaces here. So you have 3 different ribs up here that you're looking at. You have soft tissue and then the pleura, and extending from the pleura all the way down through your screen visualization, you can see that those B lines are kind of extending all the way down, and they move with the pleura as well. And so something that's really important with these lung ultrasounds or these thoracic ultrasounds is that you're ensuring that you're looking at multiple different lung regions. And so I only provide a few pictures here just because, just for the sake of time. But it's important to look because sometimes you can see these B lines in more focal areas, and that could suggest something more like a consolidation or a more local process. Whereas if you're looking at a variety of different lung regions and you see these diffuse B lines, that could suggest something a little bit more extensive and a little bit more throughout the entire lung parenchyma, as we're seeing with this patient. So certainly concerning for fluid or something like that on the lungs. And then you always want to make sure that you're catching the diaphragm. I don't have either of those 2 views for this patient, unfortunately, but specifically to look for evidence of a pleural effusion. But I can tell you that this patient did not have a pleural effusion. So overall, taking kind of the patient presentation, in addition to the echocardiogram findings and the findings on lung ultrasound, what is sort of your overall interpretation of this patient and how would you move forward with management?
Basically, it's a cardiogenic shock leading to pulmonary edema.
Yeah, I think that's great. I think that in the setting of known CHF and what appears to be a pretty severe reduction in ejection fraction or left ventricular function, as well as this significant hypertension, I'd be really worried about hypertensive emergency and flash pulmonary edema. And so what we actually did with this patient, since they did not have any IV access when they got to us, we immediately started them on BiPAP. We started diuresing them with furosemide, and we actually put nitroglycerin paste on their chest, which ultimately dropped their pressure pretty quick. We were able to get them down into the 160s within about 10 minutes. And fortunately for us, she really improved quite dramatically, to the point where she fortunately did not need to be intubated, and was able to stay on BiPAP for a couple of hours and come off of that while we got other things like a nitroglycerin drip started on her. So I think that this is just a really powerful case just to show how quickly you can make that diagnosis at the bedside and act on these patients, and hopefully even turn their clinical course around a little bit. Before I jump into some of my learning topics, does anybody else have anything to add on this particular case before we move forward? All right, awesome. So I think just a few things that I like to point out. So specifically with thoracic ultrasound, it's important to know that you can actually use any of the probes. Sometimes using the cardiac probe is nice because it fits between the intercostal spaces nicely. I personally prefer to use the curvilinear probe when I'm looking at deeper structures or looking for things like B lines or things like pleural effusions. And then when I'm looking for lung sliding, I particularly like to use the linear probe, because that specifically gives me a higher frequency and a better resolution to really look for the lung sliding. In any thoracic ultrasound, it's important to always identify that there is lung sliding. So really taking things like a pneumothorax, whether it be a big or a small pneumothorax, off the table very quickly in patients who are in extremis or crashing in front of you is very important. And so remember that when we look for lung sliding, we're kind of looking for the appearances of like a sandy beach, if you were to put M mode through it, or ants marching along a log, if you're looking at it in real time. It's important to scan multiple lung regions again because you can have more focal findings. And so it helps kind of refrain and help you hone in on your differential diagnosis. A lines are an expected artifact. So these are reverberation artifacts that are created with reflection of the ultrasound wave, off of aerated structures. And they show up as these horizontal hyperechoic lines. And so that's something to keep in mind as well. These are not pathologic. And you want to include the diaphragm so that you're really making sure that you're looking for these pleural effusions. Specifically talking about ultrasound pathology, when it comes to thoracic ultrasound, we're looking for things like B lines. So again, those oftentimes show up as these spotlights, and they're these discrete vertical lines that look like they're shining from the pleural or the pleural edge all the way down through your image. And oftentimes when we think that there's pathologic B lines, you're going to see multiple within one image. So rather than just seeing one or two or maybe three, you're going to see just diffuse B lines throughout, and that suggests some form of pathology. Lung consolidation can look a little bit different on ultrasound, and as it becomes more consolidated, you can actually see something called hepatization. And so when you're looking at the lung with ultrasound, you start to see what looks like almost a discrete organ, or what looks somewhat like a liver. And that is oftentimes a suggestion that there may be a significant amount of fluid in that lung space, or a consolidation in that lung space, and can be helpful when you're trying to diagnose something like a pneumonia. Lack of lung sliding, so we talked about that a little bit. Using that linear probe, it's really helpful to look for the ants marching along a log. If you don't see that, or if you put M mode through your pleural space, you sometimes will see something called barcode sign, which is essentially just all the tissues are static and not moving across each other, and that can suggest a pneumothorax. And you always want to be looking for effusions. All right, any questions on that before we jump into our second case, which might be our last case? All right, excellent. So moving into the second case, so now you're still in the same ICU setting. You have a 76-year-old person at this point who initially came into the hospital with a ST elevation myocardial infarction. They were able to go for cardiac catheterization and had a stent placed to the left anterior descending artery. But you've been called to evaluate them on the floor because even though it's been a week later, they had a syncopal episode. So in talking to the team, they say that he had an episode of dizziness with some lightheadedness and then had sudden loss of consciousness. This lasted for about 15 seconds, and then he was able to regain his consciousness. He had no significant confusion at that time, didn't have any chest pain, didn't have any significant shortness of breath. But now when you're seeing him, he's a little bit more confused. He's a little bit less interactive and less responsive. His medical history is included here. He has hypertension, hyperlipidemia, and type 2 diabetes. He's got a history of alcohol use and tobacco use, and there's his medications there. And you're seeing him, and you notice that he has a heart rate. He's tachycardic to 120s. He's hypotensive, 80s over 60s. He's very tachypnic, but his oxygen saturation on room air remains 95%. As you go through the rest of your examination, you notice that he has some distant heart sounds. He's tachycardic, and he has what appears to be jugular venous distension on your bedside examination. His extremities are cool. He has increased capillary refill, but he doesn't have significant peripheral edema. And on your neuro exam, he does appear to be confused, but he's moving all extremities equally. So kind of like we did with the last case, as you're approaching this patient, what sorts of diagnoses are you most concerned about? What's your differential, and kind of what particular studies are you reaching for first? Anybody can chime in. So we can continue to move forward here, but if anybody has any ideas, they're more than welcome to throw them in the chat as well.
They
Did
said
Yeah.
pericardial and
Yeah.
pleural effusion in the chat.
Perfect. All right. Okay, so our first image here, this is going to be a parasternal long axis view. It's actually a little bit off axis here, and that was largely because in this particular patient, it was very difficult to get an appropriate parasternal long axis view. So please note that not your parasternal long axis views won't always look like this. But specifically what we're seeing here is some hypoechoic density or hypoechoic appearing space here towards the anterior field. And we're also seeing some hypoechoic streaks here along the posterior aspect of the myocardium, concerning for possible pericardial effusion. And then here you can actually also see that the right ventricle appears to be more bouncy and more hyperdynamic, and that's something that we'll comment on here shortly. You then get your subcostal view. So this is actually a subcostal 2 view, but I'm using this mostly just to show us a parasternal short axis view. Again, this was a very difficult patient to get images in. So one kind of little pearl that I learned long ago is that sometimes in patients where you're not getting great parasternal long or parasternal short axis views, you can actually get a better subcostal view. And with that, you can get a very similar image where you're transecting the left ventricle and finding the papillary muscles there to get a very similar view to a traditional parasternal short axis view. So that's why you can see a little bit of liver up here. And what we're seeing in this particular video is what looks like more homogeneous, maybe more hyperechoic lucency just outside of the ventricles and within the pericardial space, again, concerning for a pericardial effusion. This is an off-axis apical 4 view, which really I didn't find terribly helpful, but we're including it for just to make sure that we're being comprehensive. And then this is a view of their IVC, which ultimately was interpreted as being plethoric with little respiratory variation. We were able to get a little bit better apical 4 view. And we actually then calculated a mitral valve inflow variation, and we'll talk a little bit more about what this is and what this looks like. But in order to obtain this particular image, you actually put the ultrasound into a pulse wave Doppler setting, and you take the gate, so this is kind of the gate here, and you place it just at the distal aspect of the mitral valve leaflets. So that's kind of the mitral valve inflow space. And what you're doing is using pulse wave Doppler to measure the velocities going through the mitral valve. And you want to map that over a prolonged period of time so that you can see if there's any significant variation in what's called the E max and E min. So these kind of big spikes here. You find the tallest point, which is going to be your E max, and you find your smallest point or your lowest point over a period of time, and that's your E min. And you compare those two measurements to come up with a percentage, and that percentage is interpreted as your mitral valve inflow variation. You can also do this with a tricuspid valve. You do it the exact same way, except you just put the gates over here, kind of at the tips of the tricuspid valve leaflets. So after your ultrasound, you immediately call cardiology and say that you believe that this patient has a pericardial effusion with cardiac tamponade. And I think it's really important to note that tamponade is in fact a clinical diagnosis. So if you have a patient who's in front of you who's acting like tamponade, has JVD, has tachycardia, is hypotensive, and has muffled heart sound, so kind of that classic Beck's triad, then you should act. This is basically tamponade until proven otherwise. And if you see evidence of an effusion, again, this is tamponade until proven otherwise. But we'll go through some of the specific echocardiographic characteristics that might point you towards tamponade rather than something else. This patient had a pericardial drain placed, and at that time had a bunch of frank blood. So cardiothoracic surgery came by and checked him out and found that he actually had a left ventricular free wall rupture, thought to be secondary to a complication to his recent myocardial infarction. He had clot evacuation at that time. They repaired his defect and he had near immediate improvement in his hemodynamics. He did very well and was discharged from the hospital about a week later. So looking into specifically diagnosis of tamponade, I think that there's a few things that I really look at when I'm trying to characterize these patients. And one is characterization of the effusion. I look for right atrial and right ventricular collapse. I look for mitral valve or mitral valve inflow variation or tricuspid valve variation. And I also look for a plethoric IVC. And each of these components can be really important in diagnosing cardiac tamponade. So first, it's important to characterize the effusion. You can see that the effusion can look differently in a lot of different cases. So here it's more just kind of that hypoechoic looking structure just outside of the pericardium. But for our case, we had a more of a homogeneous appearing, almost looks like blood or clot, kind of within the pericardial space. And then here you can actually see this is an example of infected pericardial space with evidence of these kind of septations. So you might even see that within the fluid and something that looks a little bit more heterogeneous. It's also important to note the volume that you're seeing. So you can have mild, moderate, or severe pericardial effusions. And I don't think we really have time to jump into how to differentiate between the three right this second, but it's definitely something that can be beneficial when looking at these patients on echocardiogram. So next you want to look for right atrial and right ventricular collapse. So specifically what we're looking for is evidence of an increased pressure in that intrapericardial space. So that's this space here outlined in purple. And that intrapericardial space is going to be proportional to the volume that's within that pericardial space, as well as the stiffness of the pericardium itself. And so when we think about cardiac tamponade, it's really important to kind of put it into perspective that even if you have a very small volume in that space, that can really lead to dramatic increases in pressure. And when that pressure overcomes something like the ventricular cavities and diastolic pressure, you can start to see diastolic collapse. So diastolic collapse, these are a couple of videos of some examples of diastolic collapse. You can see it here on the right side. And then you can see in this subcostal view, there's a little bit of evidence of ventricular diastolic collapse here. Those are both very useful when trying to identify a patient with cardiac tamponade. Specifically, right atrial diastolic collapse is something that's very sensitive. It's a very sensitive finding for cardiac tamponade. Whereas when you see right ventricular diastolic collapse, that's something that's quite specific for cardiac tamponade. So these are really important to look for. And something that I think that this is one of the most helpful views and ways to look for that right ventricular diastolic collapse. This is actually a parasternal long axis view, and we take M mode and you put it through here. So through the pericardial space here, through the right ventricle, through the interventricular septum, through the mitral valve, and then through the wall of the left ventricle. And you get a reading that looks like this. So specifically up top, this is going to be your soft tissue. This wave moving here, that's going to be the movement of your right ventricular free wall. This is the interventricular space here. This is the interventricular septum, or this is the ventricular space, excuse me, interventricular septum. And then this is going to be your left ventricle. And each of these waves is showing that mitral valve leaflet opening up. So again, that's going to be your right ventricular free wall. That's going to be your mitral valve there. And what you want to do is you really want to find and identify the space where this mitral valve is open. So this is ventricular diastole. And you want to compare that with what the right ventricle is actively doing at that time. And as you can see here, there's paradoxical collapse of that right ventricular free wall when the mitral valve is open. So that suggests that there is diastolic collapse here. This is kind of digging into the inflow variation. So we talked a little bit about how you can actually assess for mitral valve inflow variation. And just again, as we kind of discussed briefly with tamponade physiology, you're having increase or changes in pressures between the right and left sides of the heart, and these sort of begin to equalize. Under normal circumstances, you're going to have a decrease of flow across the mitral valve, oftentimes less than 30% with inspiration. But in the cases of tamponade, we actually see that that difference increases quite dramatically. And anything greater than 30% for mitral valve inflow variation, or anything that's greater than 60% for tricuspid valve inflow variation, suggests evidence of cardiac tamponade. And then last is really just digging into the inferior V and cava. And I think it's just important to note that there's been quite a few studies that have looked into IVC compressibility and cardiac tamponade. And what they've found is that this is actually a very good sign, a very sensitive sign, excuse me. And so if you have a patient who comes in with tamponade, almost 90% of those patients are going to have evidence of a plethoric IVC. So if you have somebody that you're very highly suspecting possible tamponade in, it can be really useful if you only have a little bit of time to look quickly at the IVC and see if it's plethoric or not. If it's not plethoric, then there's actually a reasonable chance your patient does not have tamponade. And so again, this is our patient here, which did have a pretty distended IVC. All right, so I think that we might be coming up on our time. So this might be a good stopping point. Dr. Nikravan, what's your thoughts?
Yeah, I mean, I don't know. Does everyone need to leave at 8:30? If they do, then we'll stop. If we can go maybe 5 minutes over, maybe Dr. Ferreri can quickly go through the next case. What would you all prefer? It's a cool case. It's different.
Happy to continue.
Yeah.
Okay.
5 more minutes.
Okay. Okay.
Okay,
great.
excellent. We're
So
going to go through it fast.
Okay, sounds good.
Okay, awesome. Thank you all for hanging in there. I appreciate it. All right. So moving on to your last case scenario. So this is a 60-year-old person. They were admitted to the ICU initially with hypotension and a syncopal episode. They're coming to you as a direct admission from an outside hospital, and shortly after they arrive to the ICU, they go into cardiac arrest. At that time, you start CPR. Fortunately, you're able to get return of spontaneous activity after kind of your multiple high quality rounds of CPR, as well as doses of epinephrine. But you're left with this very hypotensive patient, and you have a patient who is currently in undifferentiated shock. So ultimately, when I think about a patient who's in undifferentiated shock and I have the ultrasound probe in my hand, there's a variety of different things that I think about that we can look at to really try to guide us in trying to determine what the underlying etiology might be of that patient's shock. And so one of those things is an echocardiogram. Another is really looking at the IVC. Another is looking at the lung windows. And then another is doing a fast examination, but also including the aorta. So this is actually something called a rush exam, and that's what we're going to go through in this patient. So very briefly, unfortunately, we didn't have great pericardial views on this patient. So this is, again, a very off-axis parasternal long axis view, but it really just highlights that this patient has significant cardiac dysfunction in the setting of their recent cardiac arrest. So immediately we're concerned about potential cardiogenic shock. We're concerned that there may be some evidence of regional wall motion abnormalities. Maybe there's a component of myocardial infarction here. And so that goes very high on our differential very quickly. However, we continued through our rush examination. We quickly looked at the lungs. And what we can see here is kind of that ants marching along a log appearance as the pleura moves. And that suggests that there is lung sliding. You do this on both sides. You see lung sliding on both sides. So that really quickly takes off a large pneumothorax, like a tension pneumothorax, as the likely etiology of your, as one of the etiologies of your shock. And kind of going back to that pericardial view, I didn't see a very big pericardial effusion. So quickly, I'm thinking maybe this isn't something like cardiac tamponade causing this patient to have cardiac arrest and significant hypotension. So now you move down. Now you're moving into your fast. And this might not be something that we're quite as familiar with in the ICU setting, but this is a right upper quadrant view. So what you're seeing here, you're seeing the diaphragm, you're seeing the liver, and then as we fan through this picture, we're seeing the kidney here. And what we're looking for specifically in this view is any evidence of free fluid. So something that's going to appear hypoechoic surrounding that liver tip or that liver edge, or coming between potentially the kidney and the side of the liver here in the hepatorenal space, or possibly underneath the diaphragm. And what I'm seeing here is no evidence of significant hyperechoic fluid collections. It's a little tricky because it looks like there's a rib kind of interfering here, but nothing jumps out to me as being evident of free fluid in the abdomen on the right side. You also want to go to the left side, and I find that this is oftentimes a much more difficult image and view to obtain than the right side. Oftentimes you have to put what I was taught, you basically put your knuckles to the bed and really go posteriorly on that left side. And what you're trying to do is get the diaphragm, which you can see coming in and out of view here. This organ, this kind of heterogeneous appearing mass here is your spleen. And then you can vaguely see what looks like the kidney coming into view sort of towards the bottom of your screen here. Again, very difficult views in my opinion to obtain, but I'm not seeing any evidence of significant hypoechoic collections here that would suggest free fluid on the left side either. So now you want to move to another dependent space, and that's going to be the pelvis. And when you look at the pelvis, you want to look in both a longitudinal view like here, as well as a transverse view here. And here you're looking for any evidence of free fluid. And what you're seeing, first and foremost, you might notice, well, there is something that's well circumscribed here with something that looks pretty hypoechoic to me. That's the bladder. And so that's actually we expect it to look that way. But what we're looking for is any evidence of free fluid kind of surrounding the bladder on the spaces to the side or inferior to it. And again, I'm not seeing any evidence of significant fluid there to suggest intra-abdominal fluid. So last, you actually get an aortic view, and you kind of get this right at the middle of the abdominal aorta. And what you can see here, so in the middle of the picture is the aorta here. You can see it's pulsatile, but surrounding it, there's this kind of massive, what looks heterogeneous, like heterogeneous material. And what this actually represented in this particular case was a large ruptured AAA that was slightly contained, so an abdominal aortic aneurysm. And ultimately what we ended up having to do, so we immediately transitioned at this point, we thought, well, maybe this ruptured abdominal aortic aneurysm was the primary cause of the patient's demise and the patient's cardiac arrest. And so we really transitioned a lot of our resuscitation at that point to blood products rather than pressor first or rather than IV fluid first resuscitation. And we immediately called the vascular surgery doctors who were able to assess the patient, and given our ultrasound findings, didn't even require an additional scan. They took him straight up to the operating room, and he underwent a successful aortic repair. So we kind of went through the results here, but I think that this is a really nice examination to use in your patients that are presenting with undifferentiated shock. So it's called the RUSH exam. It's rapid ultrasound for shock and hypotension. Pretty nice acronym there. And it includes the components that we sort of walk through. So an echocardiogram with an IVC evaluation, a thoracic ultrasound to specifically look for any evidence of pneumothorax that could be causing the hypotension, a focused assessment with sonography and trauma, so a FAST examination, which is that exam that looked at the abdomen for any evidence of free fluid, and then an aorta ultrasound. So hopefully what we've been able to see through all of these cases is that the use of point of care ultrasound can be a really, really powerful tool and can be used as an extension of your physical examination. The thing that's really amazing about point of care ultrasound is that it doesn't require an x-ray tech to come up from downstairs. You don't have to wait that 15 minutes. You can roll the ultrasound into the bedside right when you walk in to first see the patient, and you can gather quite a bit of information quite quickly that can help point you or at least guide you in your management of that patient. So it really allows for that rapid assessment of patients in shock or extremis, and it's a tool that allows you to quickly wean your differential diagnosis. And even though multiple things could be happening to your patient at once, it can certainly help you focus in on something that may be the kind of the underlying cause of their recent decompensation. So hopefully today, after going through all these cases, we saw that we had a case with flash pulmonary edema that was identified on thoracic ultrasound, which was able to be treated at bedside. We had a case of a patient with cardiac tamponade who ultimately was able to go to the operating room and was found to have a left ventricular free wall rupture. And then we also had this patient with a ruptured aortic aneurysm that led to cardiac arrest and ultimately was able to go to the operating room with vascular surgery, thanks to bedside ultrasound. So I want to just acknowledge, thank you again very much, Dr. Nikravan, for giving me the opportunity to present today and for the help in kind of looking at these slides. And then I also want to give a shout out to Dr. Megan Frederick, who trained at University of Cincinnati and is now emergency medicine faculty there, who helps me gather some of these images, which I had in residency and couldn't get my hands on. So here's my references. I really appreciate all of your guys' time. I know that we're a little bit over, but if there's any questions, I'm more than happy to answer them.
Wow, Dr. Ferreri, what an amazing case conference. This was so exciting and so well put together and presented. I just cannot thank you enough for this wonderful exposure to some really impactful cases that ultrasound helped expedite and affect the management of these patients in such an impactful way. So thank you so very much. I know we are a little over time, but just wanted to see if anyone had any questions that were burning that they didn't throw in the chat for Dr. Ferreri. This is so great. We have Josh in the chat. I don't know if you can see, but Denise Jaffe said, "Thanks, great presentation. You seem like a great clinician and a humble guy who always wants to learn." That says a lot coming from Denise Jaffe. She's one of our cardiothoracic congenital pediatric anesthesiologists who is as smart as a tack. So she's really great, sharp as a tack.
I have one question for you guys.
Yes.
In the case of a lot of secretions present in the lungs, like copious amounts of secretions, what has your experience been when it comes to lung ultrasound? What findings have you found?
I have to say that I personally haven't found ultrasound to be overly useful in identification of significant secretions, but Dr. Nikravan, I don't know if you've had a different experience.
I have had patients who have had really significant, I would say, pulmonary edema, like flash pulmonary edema. When you put the, suction catheter in, it's just pouring out. In those patients, I've seen it more look like consolidative lung. For secretions in particular, I haven't seen much in that way, unless it's been like a pneumonia or there's been consolidative processes with dynamic air bronchograms, and you can see kind of the bubbling up within the bronchioles on the lung ultrasound imaging, which is really impressive. And is something that we use to kind of differentiate static from dynamic air bronchograms within lung ultrasound. So like consolidation versus pneumonia, an infective process. But in regards to secretions in particular, I don't have much to say about that because I haven't seen too much.
All right. Thank you.
Yeah.
Thank you, Kapil. That's really great. I just want to sing your praises for a second. Fanny Nuke says, "Great cases, thank you." And then Chris says, "Great cases, thank you. First case, did she really have COPD? Obviously not a POCUS diagnosis."
She did have COPD, which actually really complicated, I think, their initial presentation, especially because we heard wheezing on their examination, and the initial thing to jump to, everybody wanted to jump to, was duonebs for the patient. But it was really, really helpful in getting the point of care ultrasound, because then we saw that kind of diffuse airway disease that was concerning for pulmonary edema. And that's sort of what guided us towards treating more for SCAPE or flash pulmonary edema in that case.
Great. Well, Dr. Ferreri, thank you so very much. I hope you all have a really fabulous day today. We started off with a bang with an amazing case series. And like Dr. Ferreri said, if you have any questions, please feel free to reach out. I don't know, Josh, if you want to throw your email address or so in the chat, just in case anyone has any questions, they can reach out to you. But
Yes.
we're excited. Hopefully we'll see you all again next month as well.
Awesome. Thank you so much, everybody. It was a pleasure getting to meet you virtually.
Bye.
All right. Bye, everyone.